Now I have to live up to the introduction, so that's the next step. Optimizing function in the neuropathic foot. The primary goal in the management of the neuropathic foot is ulcer prevention. Over the years, I've had my share of diabetics, but I have not had my share of DFUs. So why is that? Am I a lucky guy, or is that just because I have a very compliant patient population, or is that because I took the time to ascertain what are each of these individuals' risk factors to be able to thwart the progression of DFUs in an at-risk population? So pathomechanical foot and limb function precipitates and perpetuates ulcer formation. Identification and neutralization of the conditions that have created this dysfunction is critical. So James is 84 years old. He's an active guy. He has HIV for a long time, DM2, peripheral neuropathy, Charcot, zone 2, and severe pedal pathomechanics. "45% of the time, it's in zone 2. Obviously, the left foot, this is a recent x-ray, the left foot is much more severe than the right foot. I saw him initially. He had an auto accident a couple of years before I saw him, and he fractured his left lower leg, fibula, and he was in to see me because he had a right ankle sprain. And I said, "Do your feet hurt?" And he said, "No, they don't really hurt." That's because he didn't know how much his feet were dysfunctional. The reason I put this up, this is a typical exam that I do for every single patient. And I first saw James in March of 1986. And I just saw him in April of 2024. And I've seen him every couple of years at the least to do this examination. And we've prevented James from developing the kind of breakdown that you would see in an individual with his problems. And more importantly, if you look at that examination from 1986, so a 38-year follow-up, his arch morphology seated was completely flat. And here it is 38 years later, and the left foot, the more severe foot, had a low to medium arch morphology. And the right had a high arched foot, off weight bearing, which he had low before. The problem is that when he goes to use those feet, even his foot of today, it collapses inappropriately, and it fails to maintain the ability to support the superstructure and stably allow the body to transfer that pressure forward over the foot with each step. The other problem is that he had good internal hip rotation in 1986, and 38 years later, due to aging, due to his processes that have been going on, he has almost no hip rotation. So if your foot's collapsing, you need that hip rotation in order to go along with the pronation. If you don't have it and the foot's not functioning well, then there's a constant state of tension in the lower extremity. So that precipitates more stress into the foot and ankle. He had normal hamstring length in 1986. And now his hamstrings are 2 to 3 inches tight, right and left hamstrings, fingertips to toes. So each inch gives you about 20 degrees of additional forward motion with each step. So that increases. So you still go forward because the arms are swinging and the hips are moving, but you go forward with tension. So that increases the stress on the foot. He had a total varus. Total varus is the amount of collapse of the foot. It's the total frontal plane influence of the entire body into the foot. And I've always measured that, and that was a measurement that was started by Dick Schuster and Dave Sklier. And now today, his total varus is more than it was when he first came in due to gravity and aging. So 45 degrees today, and it was 20 to 32 before. His dorsiflexion was limited then, 0 and -8 degrees, and today it's -3, not better, and +5 on the right. So the right is pretty good. The left needs work. So now I have this person doing hip internal rotation exercises, strengthening the appropriate musculature, and lengthening the Achilles tendon. As Dr. Jacobs pointed out, you need to have that Achilles tendon working to at least allow forward passage of the body over the supporting foot. He had adequate dorsiflexion when he first came in at the first MP joint. He's lost 20 degrees on the left side. He's not playing tennis, 45, 55, that's plenty of motion. So that's not contributing to the problem. His eversion, subtalar eversion, was 0 and -10 degrees. And now his subtalar eversion is +2 and +5. So he hasn't lost anything there. The total range of motion has gone down a few degrees on the left, and it's the same on the right. When people talk about forefoot deviation and forefoot varus, that's a very common finding. I talked about that last year at this seminar. So it was 35 degrees in 1986, and it's the structural deformity. So it's still, I measured this year, and I don't look at the old ones when I do it. And I could give you every 2 years of his progression in looking at this, and I can pull 100 charts and show you the same thing. So it's still 36 degrees. The right has increased. So you want to wonder whether or not some of that right is forefoot supinatus or some other deformity. As we move forward here, the right hip was lower, and it's still lower, indicating that the left limb is functioning as a longer limb. His angle of gait is straighter than it was before because he's been in some type corrective device over the years. When he first came to me, he had nothing he was wearing in his shoe, no orthotic device. And now, today, he came to me, and he was wearing an orthotic that I prescribed for him in 2021. And the reason why he was wearing that is because he went to see another podiatrist in his plan last year, and that podiatrist prescribed a UCBL, and the numbers there show that it didn't hold his foot any better than without the device. 35 and 40 degrees, virtually the same. It was 45 degrees without the device. And yet, so he was wearing, he said, my feet still hurt. And so then he went back to the device I gave him, which was a DSIS type device. So this is his barefoot, current barefoot testing. And what you see there is some increased pressure on the first. This is much better than before, but what you also see is increased pressure on the lateral border of the right foot and more on the medial border of the left foot. The center of force line is deviated medially on the left foot and laterally on the right foot. You could see more pressure on the left side than the right side. It's easy to see here. I do computer-assisted gait analysis on all my patients, and I've done that since I've been in practice. So I have all these tests. They're all documented. They're all on the computer, and everything's cataloged. So if you look at the wave versus time curves, the left, you see the calcaneal curve is the purple curve. And that one is a bit longer. Both of them are too long, and there's too much pressure. It approaches almost 60 pounds through the heel there and 50 on the right. So there's a difference from right to left. Also, the first MP joint is out from the pack, so that it's taking more pressure, and it's a more severe problem on the right side than the left side. The lateral border of the foot is more depressed left than the right side. So if you look at this, the stance is greater left, and this is lab work for me. I don't understand how anyone that treats feet that are at risk of degeneration and ulceration doesn't obtain and ask for this information. Every hospital, every group should be able to document the pedal pressures and the phases of gait and temporal parameters. So the mid stance is way above normal. It's 39 left and 30 on the right. Propulsion is low, and active propulsion is terrible. Passive propulsion should always be greater. Active propulsion should always be greater than passive propulsion. And passive propulsion is equal. Single support is greater left, and initial and terminal double support doesn't match. 103 steps a minute, so he moves. He gets around, but his heels are on the ground too long. And people say, well, how come they're even if there's a limb length discrepancy? They're even because you're able to equal a load, because there's nothing restricting your foot from doing anything it can and has to do to make it more symmetrical. So if you look at this barefoot, again, and then we look at shoes, that's why barefoot's not good. Anybody that tells you that barefoot is good for any reason doesn't know what they're talking about. Barefoot is only good if you live in the jungle, because it conforms well to the surface. But other than that, forget it. So there's some increase in the limb length discrepancy on the right side with the shoes. You look at barefoot versus shoes, and then we have shoes, much better than barefoot because all the weight in the forefoot is more evenly distributed. But there's a reduction in pressure down to 40 pounds on both, and more even. But there's also a difference from left to right, but not as bad. And all the numbers are lower. Now with 3822, still zero active propulsion. Passive propulsion is still greater, single support greater left, and these numbers are not better. And we have a 16% difference from the left to the right. So then I took a cast in neutral position. If you can move it, you can improve it. So people say, oh, somebody's old, they got this thing, they need accommodation. Not true, not true. If you can move it, you can improve it. So if you can reposition them, look at how wide that left foot medial arch platform extension is. And this controls his foot. This gives him 0 degrees. There's a metatarsal pad. There's a dimpling and modification and cushioning for the navicular on the left side. And it's into neutral position. So there's the shoes, and there's the UCBL. Marked difference. The other thing that you see when we show you more pictures here, I want to be able to get to the end of this. You see he's leaning to the right side. Shoes versus UCBL. And then we have much more even, but the numbers are coming down, but it's not completely even. You still have 0 active propulsion on the left. Single support is equal. Initial and terminal are good. And we have a 20% difference. So there's the UCBL, and there's the lowering of the pressure. And here's shoes. And here's UCBL. That's a problem. Flat lines they're supposed to be smooth curves, waveforms. And when you have those flat lines, that's no good. In the UCBL, you have no more flat lines. Here's the UCBL with a 3/8 inch lift on the right side. So the lines start to straighten out, and then you see the more even distribution of pressure. However, the forefoot on the left side still doesn't take as much pressure as it should. Stance and swing are even. Mid-stance is much better. Up to 30 is the adult norm. 18 to 22 is like high school athlete. So like 30 to 25 mid-stance, and you have active propulsion. So this is a marker. Active propulsion in somebody that had 0 before, that's able to push off with normal amount of pressure. That is a muscle pump too. So that's another thing that helps. So +6 on the left. And then his passive propulsion is still greater than active on the left. Single support is equal, initial and terminal are great. 102 steps per minute, which is a great speed, and 11% difference. So this is 90% better than when we started with him. So here's UCBL with a lift on the right, and this is UCBL without the lift. So you see there's a difference. Now here's UCBL with a lift on the right again. So much better, one to the other. Now here's UCBL plus an insole on the right side. The insole is not used to elevate the right side. So what do I use it for? I'm using it to dampen that side to reduce the speed on the shorter limb. So it has to slow it down, so it doesn't get to the end as fast, so that the other side can function more appropriately. And so when you look at this, you see there's no pressure on the ball of the left foot, very little pressure. And now you see much better pressure. That's with the insole. Amazing. So 3/8 inch lift on the right, 84 years old, with all these risk factors for 38 years. And he's still going strong. UCBL, and you see the insole, you see the difference in the pressure distribution. Numbers don't lie. 62, 61 stance, that's normal. If somebody looked at this, if a student or a resident looked at this and said, tell me the age of this individual, they would say 25, 35, like that. Mid-stance, 28, 28. Propulsion's 24, 24. Active propulsion is greater than passive propulsion on the worst limb, the left limb. We went from 0 to 13. And single support is equal. Initial and terminal are equal. 107 steps a minute. People walk faster if it's easier. 6160 calcaneal stance duration. So, in closing, it's been my experience, based on careful observation and analysis, agreeing with reason and a benefit to all patients, that the identification and neutralization of structural imperfections in the neuropathic foot, along with its correspondent pathomechanics, substantially reduces the risk of ulceration. Ladies and gentlemen, thank you very much for your time and attention.